Oh, Christian, sorry, forgive me. I thought your name was Patrick. I know we met not so long ago, but I didn't quite remember your name. Thanks to the president of the SRLF, Gilali. It's rather strange for me to be on the podium with the title you just given me, because I'd attended the SRLF for 25 years with the aim of discussing tisular oxygenation. I'm coming back in a different capacity, somewhat new for me. So before beginning my talk, I'd also like to stress Christian Rambaud's point, because he mentioned the role of the INVS in regional national organizations for health surveillance. It's a particularly hot topic at the moment that will require considerable work in the next 6 to 12 months, that will involve us closely with the INVS and with Françoise Weber. And the second point I'd like to mention is that INVS is in the areas. It's also part of the DGS, and we'll see this is one of the points that I'd like to present here, because, as you know, the Health Authority has part of its mandate to cover its health agencies, and we'll see that they are numerous, thanks to SRLF, to allowing this presentation by the Health Authority that's actually not well known. It's an authority that we, physicians, I'm also an anesthesiologist, intensivist, we know the health supply agency rather than the health agency, even if the term health should resonate with us as health professionals, probably because DGS is first and foremost in charge of prevention and public health, but also, and it's the topic of this talk, everything that pertains to surveillance, health emergencies, and works in close conjunction with health professionals in the broad sense of the term, with the other division of the health ministry for healthcare. So as part of this effort today, there's an initiative, and thanks to putting to this question of strong regional approach, the RSs were set up just over 3 years ago as regional authorities, allowing them to manage on a regional basis problems that come within their scope. Just imagine that Health Watch as regards risks for mosquito, dengue fever is not the same in northern France as it is in southern France. In the north I come from, there's no dengue fever, or it's not the same as what's to be found in southern France. So regionalization makes sense both in terms of the health solutions, but also health monitoring. So the Health Authority serves to coordinate at national level. It has numerous coordinating missions. It doesn't work alone. Other ministries that can be involved in health risks when they become extremely broad-based, transport, labor, national education are contaminated by a pandemic, flu or otherwise, and so there's a joint ministerial approach in respect of infectious diseases or any other health crisis. We'll see also, as was extensively presented by Françoise in her talk, that viruses, germs, but also radioactive clouds, all sorts of pollution, heat waves, of course, know no borders, and the world as we delineate it offers no borders to mosquitoes. So there'll be an international issue here. We'll return to that. So, in fact, as I said, it's very important. DGS that supervises health safety does this with agencies with various missions, and much is said about food infusion in neonatal resuscitation and the difficulties it represents for the medicines agency at our side. But you see that it's also very interesting because, in fact, these are infectious agents in the parenteral nutrition bags, and so involves the healthcare authorities. So there's all about pharmacovigilance and also combating infectious risks involving our agency. So you see, when we talk health safety, we involve many schemes. Françoise and I meet every week because the health authority brings its agencies together to do an update on all elements pertaining to national health. So we have to forward everything that's happened in France, in the West Indies, the chikungunya that's developing slowly, or in French Polynesia, or the Zika has also wreaked some damage of late, with pretty fierce Guillain-Barré tables that didn't really interest the media, but there were other topics on the radar screen. The health ministry works with various divisions, and I mentioned the healthcare agency, also social security, social welfare. When there's a health risk that emerges, you might have to put in place funding schemes through the social security, so divisions must work jointly. Lastly, interacting with the ARSs, I mentioned that. So we have a room, like paramedics. When we see this room, it's like a kind of a regulating room. It's a bit like being in Lille. It's called the Chorus, which is a national focal point that collects the signals as they emerge in France or beyond. It was set up in 2007, and it's an operational unit to act as part of these emergencies. In fact, it's similar to what can be seen for civil protection, where operational watches interact. INVS have their own operational control room where people can work and be on duty 24/7. Chorus manages any event on health or safety. Obviously, as soon as it affects the national territory, or there's a need for foreign response intervention, and this with an operator, also an agency, EPRUS, to deploy forces from reservists. Some of you may be reservists and overnight can be sent on a health mission to a foreign country. For Polynesia, we sent an anesthesiast, 2 nurses. They're not just physicians or healthcare manager. When you have management, I mean, people have to organize staff rotations, etc. So a health manager to see how best on site, how to better organize resources, or if not, by dispatching some, and all that needs to be planned. So just returning to what François presented, the place of DGS in terms of these other stakeholders and the alert mechanisms. You have the Health Watch Agency, the other agencies that will receive signals, forward them, and this signal transmission will at some point be focused on DGS in order to take operations decisions. The agencies don't trigger themselves these operations, but it goes via the health ministry. As I've said, I'll repeat, there are European international ties with alert messages going from the focal point Chorus to the European Commission. The alert messages referred to by Françoise, European Warning Rapid Signal, and information to WHO in conjunction with international health regulations. These are people who read on a regular basis in order to organize the alert and response mechanisms. There are regular meetings held with groups of varying size, with subgroups looking at various problems within WHO, or the health safety G8, major countries plus 2 large countries, Mexico and Canada. So decisions are taken to share information and to define actions. There's a whole process at present on the sharing of strains. When we have a viral problem, we want to develop a vaccine. Well, countries frequently, and it's the case of MERS-CoV, in countries where these viruses emerge, may find themselves without the strain. If you develop a vaccine that will be sold to millions and billions of people, there needs to be a recognition of the country that supplied the strain, even royalty. So there's a whole question about the ownership of strains and protection of biodiversity and what can be used. There's a chapter being developed on that internationally on that. But problem when you want to develop vaccines rapidly, it's perhaps wise not to protect these strains at country level, in which case it won't be possible to develop therapeutic weapons against that. So the GHSI is putting in clauses aimed at protecting the acute emergence of infectious diseases and the health response to achieve international coordination on health response events. Just to repeat briefly, in the case of major crises, we also have exercises to prepare for that. Preparation is of the essence in the dissemination of health warnings with the involvement of other groups in French government departments that can respond with the health authority. Let me just cite some points as regards the stakeholders who can be involved. EPRIS, as I mentioned, amongst the agencies that are regularly involved, the ANSES that deals with the environment, everything that pertains to animal health, and likely could find itself when a trans species, the MERS-CoV, to see the role of the animal reservoir and how an animal condition becomes a condition that slips to humans. You can also cite EFS. Why? Because if you have a pandemic, an infectious crisis such as chikungunya, well, the donors will become a problem, and so you will no longer be able to readily assure blood transfusion from infected donors. So there'll be a scarcity factor. We'll have to put in place schemes to offset the loss of a particularly abundant site in terms of number of donors. Second, broad point in terms of interaction or outreach between stakeholders and ministries. There's outreach to country health professionals and outreach to professionals. Healthcare Authority has set up very interesting messages that you see. You may have heard some. There are two possibilities to see these warning messages. They're MARTs, they're rapid health warnings delivered to heads of institution. When these warnings are sent out, they disseminate them within to inform staff, but we're not always sure that when a head of institution receives this warning, it's disseminated. And then there's the urgent DGS, which is voluntary. That is, these are professionals, and you can do this, who enroll on the DGS site to receive the warning messages when they are sent out. But that's on a voluntary basis. So we're trying to disseminate the network of physicians associated to health care warnings. So when the warning arrives, a number of people, maximum number, can be informed. In the case of MERS-CoV crisis, other warnings, contacts with learned societies for expert views, etc. The health crisis is also a media crisis, as we're currently experiencing. There are as many critical factors in communicating and in managing a healthcare crisis, personnel, isolation, etc., because you have information that prompt worry, concern. You'll have hundreds. We saw this with Françoise of notifications, people who will turn up spontaneously because they have some of the symptoms described or they've been in contact with a person with similar symptoms. Not the case. We had an aircraft landing from Saudi Arabia, which was stopped with everyone inside, put into quarantine immediately at the local hospitals because one of the people had coughed and sneezed in the aircraft. Given the hazardousness and the mention of the Moscow follow-up, they all ended up in hospital, which is better than prison for examinations, etc. And the way concern can spread is key. And then, of course, there's misinformation by amplifying, hyping news, trying to seek out in a justified or questionable manner information that would challenge the way in which healthcare systems are organized and the way leaders have taken decisions. That's rather challenging, and so it must always be simultaneous with crisis management. We must manage the communications crisis that can erupt. Here's a warning on 12th of May when the Lille case, which from Douai and then Valenciennes, a patient who moved around a bit, but Hugues will return to this later, who was sent by DGS, and the rapid health warning which had been sent a few days prior to that to explain the good measures in healthcare institutions, to isolation, etc. What's important, as Françoise mentioned, what we're trying to avoid, it's not always possible here. It's the pandemic peak. This was the case of a flu pandemic in the simulated cases in our institutions and our ministry. Obviously, what's important is the braking phase to prevent introduction, and of course, introduction is to seal off borders. Airports not always easier, and it's often too late when the positions are difficult to take. Doesn't mean that you shouldn't continue to bolster health police at borders, but it's not always easier. However, propagation can be a key factor with health isolation measures, and it's a key phase in managing the crisis. In the remaining minutes, I'd like to discuss briefly how to build the capability in France, just to review some of the coordination points without going into too much detail. I'm sure Françoise has said a lot about that, as well. Benoit. As part of the MERS-CoV, there were the anticipation phases, and then the episode spreading without knowing when it began how severe the episode would be, and the post-critical management phase with repeat episodes. Françoise has said everything about the way in which the case arose. Let me just stress a couple of points at the outset. There was, this is a key concept of human-to-human transmission, because the first case is reported in the UK with a reference to the health professionals affected in Jordan, seemed to indicate that it could be transmitted very quickly. And so that was a note of concern, knowing that the first cases had been notified since the end of 2012, and in countries that were far from the initial area, there were cases developing and transmitting with contacts. So at the DGS, we have a point of contact that's very interesting, who's the High Council for Public Health. You'll see this about vaccination, how to manage a number of infectious risks, but also other types of exposure to lead or to other pollutants. And so they emit opinions on the basis of what the literature has to offer, as well as some additional work that can be conducted. So the advantage here is that they're very responsive and that they can adapt to give you a number of recommendations. Of course, he doesn't act alone. He acts with experts on infectious risks, and Bruno's involved on that. So opinions were given and a number of instructions identified with the various learned societies. Benoit will discuss the case in May. Just a photograph here, because I find this one rather amusing. It was the press conference organized by the health minister in Lille when the first case erupted. I know it would get Benoit to smile, because here you have Daniel Mathieu, who's in charge of the resuscitation unit in Lille. Here you have the head of accident and emergency, Patrick. Some of you were the health minister here. And at the time, I was in charge of that institution. I can promise you and swear to you that if I was told that I would get this job, I would never have believed you. So I find it quite amusing just to kind of cock a snoot at that a few months after that Moscow episode, which I promise you has nothing to do with subsequent events regarding my own personal history. So, information that's interesting in how the first cases unfolded, over and above what I've already said, travel advisories, telephone call centers to take calls, respond to queries, airport management, the interaction with Europe, WHO. There was a key point, which was that the risk, identifying the animal reservoir, zootic, and so it was the Animal Health Authority that dealt with that. And then there was an issue that Françoise touched on tangentially, which is biological diagnosis, because it's in the presence of a new virus, the ability to identify the virus, to provide information swiftly about it is a key point. When the samples go off to the National Reference Center, that's some distance away, it takes time. There's a need for responsive exchange of information so that other biology centers can follow the same method and develop appropriate technology to perform the biological test and diagnosis. I'll stop there because I think all this has been said by Françoise, so we still have the current state of play, maintained vigilance, nevertheless a form of reassurance in terms of a degree of risk which hasn't been borne out. That's probably why there are fewer of you than expected in the room had the threat become full-blown. This is true for a virus that we're familiar with, and were the virus to transform itself, it could readily acquire new capabilities, so there's a need to remain watchful, vigilant, and you've seen that in certain areas it's continuing to grow and burgeon. So the risk is genuinely nosocomial. Benoit will probably tell you a bit more about that, but we've seen contacts that were made with patients who were suffering with healthcare professionals. That was the case, I think, of the first cases identified from Jordan. Okay, thanks for listening.